In this video, I'm going to talk about different obstructive disorders, their clinical presentations, as well as the mechanism of action of different medications that are used for the treatment of obstructive lung disorders. But before doing that, first I would like to differentiate between the obstructive and restrictive lung disorders. So with obstructive lung disorders, due to the obstruction of airflow, air will be trapped inside the lungs, as a consequence of which the residual volume will increase, and thus these patients will have an increased total lung capacity as well as increased FRC. In these patients, there is a significant decrease in the level of FEV1 as well as a decrease in the level of FVC. But then because the decrease in FEV1 is more than FVC, therefore there would be a decrease in the FEV1 over FVC. So just to explain what these terms mean, FEV1 stands for forced expiratory volume in 1 second. So the amount of the air that can be exhaled in 1 second is referred to as forced expiratory volume, while forced vital capacity is referred to the total volume that can be exhaled from full inspiration to maximal expiration. So in these patients, the FEV1 over FVC is decreased and its value is less than 0.8. So patients that have normal lungs, FEV1 over FVC is about 0.8. So in these patients, it's less than 0.8. And then DLCO refers to the diffusion capacity of the lung for carbon monoxide. So with the obstructive lung disorders, it's only the emphysema that causes a decrease in the DLCO. And the reason for that is that with emphysema, there is a destruction of alveoli, as a consequence of which the diffusion capacity of carbon monoxide will decrease. And then in patients with restrictive lung disorders, as the name implies, there is a restricted lung expansion, as a consequence of which there would be a decreased total lung capacity. In these patients, there is a decrease in FEV1, but then decrease in FVC is more significant, and thus there would be an increase in FEV1 over FVC ratio. So the level would be more than 0.8 in these patients. And then there are two different types of restrictive lung disorders, the ones that are affecting the chest wall, and thus these patients have a restricted lung disease. For instance, if a patient is obese and cannot breathe from the obesity, or if there is a structural abnormality of a chest wall, then that would be a kind of restrictive lung disorder. But the diffusion capacity of the carbon monoxide in those patients will be normal. Versus the second type of disorders that are causing restrictive lung disorders, and those are called intrinsic lung disorders like fibrosis, pneumoconiosis, sarcoidosis, and so on. And with these conditions, since there is a thickening of the blood-air barrier, therefore the DLCO will decrease. So next, I would like to go over the obstructive lung disorders that are listed here, and the 4 obstructive lung disorders include chronic bronchitis, emphysema, asthma, as well as bronchiectasis. So first, starting with chronic bronchitis, the definition of chronic bronchitis is referred to as a productive cough of more than 3 months per year for more than 2 years. So a productive cough of more than 3 months per year that is being there for more than 2 years. And in these patients, there is an excess mucus production, and in addition, due to the hypertrophy of the mucus secreting glands in these patients, the RAID index, which is referred to as thickness of the glands over the thickness of entire wall of the lung, is more than 50%. So again, the hypertrophy of the mucus secreting glands in these patients will cause the RAID index to be more than 50%. And then the clinical presentations of chronic bronchitis include wheezing, crackles on listening to the lungs, as well as cyanosis. Now, the other term that is used to describe the chronic bronchitis is called blue bloaters. So these patients are usually overweight and are associated with cyanosis, as I mentioned earlier. So the other term for it is blue bloaters. The next condition is emphysema, where there is a destruction of alveoli in these patients, and thus diffusion capacity of the carbon monoxide is decreased in these patients. And there are 2 different causes of emphysema. Number 1 is smoking, and number 2 is the alpha-1 antitrypsin deficiency. So what smoking does is that it increases the activation of PMNs as well as the macrophages, which will cause increased elastase activity, and thus it will destroy the alveoli. On the other hand, alpha-1 antitrypsin is the antiprotease enzyme that will stop the action of the elastase. So patients that are deficient in alpha-1 antitrypsin will therefore have increased elastase activity. So both smoking and alpha-antitrypsin will lead to increased elastase activity that will cause destruction of the alveoli and cause emphysema in these patients. And then one difference between these two mechanisms is that smoking is associated with the centri acinar emphysema, which means that it affects the proximal respiratory bronchioles, while patients with alpha-1 antitrypsin deficiency develop the pan-acinar emphysema, and as the name pan implies, it means that the entire acinus is being affected. And then these patients clinically present with a lot of effort in order to be able to breathe, and thus because of the efforts that they put, it's referred to as pink puffers. So since they get facial flushing from a lot of efforts, it's called pink, and since they require again a lot of efforts, it's referred to as puffers. These patients use accessory muscles during breathing, and they also will breathe through pursed lips, and the purpose of that is to increase the airway pressure and thus prevent the airway collapse. The next condition is asthma, and these patients present with the triad of the inflammation, hypersensitivity, as well as the reversible obstruction. And other characteristics of asthma include the smooth muscle hypertrophy, Korschmann spirals from the shed epithelium, as well as the Charcot-Leyden crystal from breakdown of the eosinophils. And then characteristics of asthma include the dyspnea, wheezing, bronchospasm, as well as the goblet cell hyperplasia with the mucus plug. And then finally, you should know that there are two types of asthma, and one is the extrinsic asthma, which is due to the type 1 hypersensitivity reaction, and this is an allergic reaction that usually have a positive family history. And then type 2 is called the intrinsic asthma, which is due to the respiratory infections like viruses. It could be from stress, exercise, cold temperature, or aspirin side effects. And finally, we have the bronchiectasis, which presents with the permanent dilated bronchial walls from the necrotizing infections. And so for the diagnosis of the bronchiectasis, you will have to use a high resolution CT scan, and this is the diagnostic test of choice. And then conditions that can cause bronchiectasis include, for instance, the cystic fibrosis, which prones these patients to recurrent infections. As I mentioned earlier, of course, infection is another cause of bronchiectasis. Smoking and Cartagener syndrome. So smoking and Cartagener syndrome, both of which will decrease the ciliary motility, as a consequence of which, again, there would be an increased risk of infections in these patients. And then finally, the bronchopulmonary aspergillosis can increase the risk of bronchiectasis development. And these patients present with the dyspnea, hemoptysis, cough, and a mucopurulent, foul-smelling sputum production. So here I have provided you with images of the barrel chest as well as bronchiectasis. So here you can see in the bronchiectasis there is dilated bronchi in these patients. And then barrel chest is seen with the emphysema. And this is given the name barrel chest because, as you can see, the lungs have a barrel appearance, versus the normal lungs, which would have an appearance like this. So in this frontal view, you can see that there is flattening of the diaphragm and increased air spaces in these patients, but the barrel chest actually becomes more evident when you look at the lateral x-ray. So here is an example of a lateral x-ray. So you can see that the anterior-posterior diameter is actually increased in these patients. And if you draw a barrel here, you can see that the chest has actually the shape of a barrel. So back to the topic. So again, these patients develop barrel chest with the emphysema, which was commonly caused by smoking as well as the alpha-1 antitrypsin deficiency. And then two of these conditions, chronic bronchitis and emphysema, are referred to as COPD. These conditions could be presenting separately, or sometimes they would be both present in a patient. So emphysema, also known as pink puffers, I explained that since these patients are taking a lot of efforts to breathe, then they are referred to as puffers. And since they would take a lot of effort, they would develop facial flushing, for which the name pink is given to them, pink puffers. Again, from a lot of effort, they would have a lot of energy expenditure, for which these patients are usually thin. They have a barrel chest appearance, and their expiration is through pursed lips to increase the airway pressure and thus prevent the airway collapse. And then finally, these patients are distressed, as I mentioned, given the name puffers, and use accessory muscles during their breathing. Versus patients with chronic bronchitis, which are usually overweight and are cyanotic, giving the name blue bloaters to it. It causes a chronic cough production of more than 3 months per year for more than 2 years. And they have a lot of sputum production, for which the rate index is more than 50% in these patients. But unlike the emphysema, these patients do not have any distress during breathing or do not use the accessory muscles. So next, I would like to go over the mechanism of action of different asthma drugs that we have here. So first, we have the beta blockers like albuterol or salmeterol. And these medications, what they do is that they stimulate the beta-2 receptors, as a consequence of which there would be an increased level of cyclic AMP that causes smooth muscle relaxation. But one side effect of beta blockers is that they would cause hypokalemia, and thus the side effects of these medications include tremor and weakness. Next, we have the muscarinic antagonists like ipratropium, and these medications, as the name implies, are muscarinic antagonists, so they decrease the vagus-induced bronchoconstriction. And these medications are extremely useful for the treatment of COPD, and one reason for that is that these medications, since they are antimuscarinic, they decrease the bronchial secretions. Next, we have the theophylline, which inhibits the phosphodiesterase enzyme, which normally breaks down the cyclic AMP. So by giving this medication, there would be an increased level of cyclic AMP, which causes the smooth muscle relaxation. However, you should also be aware that this medication also blocks the adenosine receptors, as a consequence of which the overdose of theophylline can cause arrhythmia and tachycardia. And so if these patients develop tachycardia, you will have to treat them with the beta blockers. The next classes of medications are leukotriene antagonists like zafirlukos and montelukos, and these medications, they block the leukotriene receptors. And leukotrienes are causing the contraction of the bronchial smooth muscle. So by blocking the receptors in these patients, you will inhibit the bronchial smooth muscle contraction. Next, we have the 5-lipoxygenase inhibitors like Xylitol. And these medications inhibit conversion of the arachidonic acid to leukotrienes. So here, let me show you the pathway. So we have here the phospholipids, which will be first converted to arachidonic acid via the phospholipase A2 enzymes, and then arachidonic acid via the cyclooxygenase will be converted to prostaglandin and thromboxane, and the medications that stop cyclooxygenase used for pain as well as the control of fever and inflammation, and these will be discussed in a separate video. And then here the medications that block the conversion of the arachidonic acid into leukotrienes, like for instance Xylitol, which inhibits inhibits the 5-lipoxygenase, or the medications that block the leukotriene receptors like the montelukast and zafirlukast are used for the treatment of asthma. So back to the topic here we have, so Xyloton prevents the conversion of the arachidonic acid into leukotrienes. Next we have the corticosteroids, which inhibit the phospholipase A2 enzyme, and thus they would decrease the synthesis of the arachidonic acid. So let me show you the pathway again. So here we have the phospholipids that via the phospholipase A2 are converted to arachidonic acid, and later on via the 5-lipoxygenase enzyme converted to leukotrienes. So corticosteroids will block the phospholipase A2, and thus phospholipids can no longer be converted to arachidonic acid. And then you should also know that corticosteroids are the first-line treatment for the long-term control of asthma. You should also be aware of the side effects of corticosteroids, which include, for instance, hypertension, hyperglycemia, as well as the osteoporosis. Next, we have the cromolyn, which inhibits the mast cell degranulation, and thus histamines will no longer be released. And this medication is used as a prophylaxis for asthma. And so the memory aid that I have here is that crows eat hissing snakes. So crows goes for cromolyn, and hissing goes for histamine that is no longer being released from the mast cells. So cromolyn is crows that eat hissing snakes. And then finally we have the omalizumab, which is the monoclonal antibody that acts against the IgE. So it is an anti-IgE antibody, and thus it prevents the degranulation of the mast cells. And this medication is used for the treatment of the allergic asthma in patients that are both resistant to the steroids as well as the beta-2 agonists. So next, I would like to go over the treatment options that are available for COPD. So far I've discussed the medications that are used for asthma. Next, here I'm talking about COPD. Conditions that cause COPD, as I discussed earlier, include emphysema and chronic bronchitis. So number one treatment, and most important in the COPD treatment, is smoking cessation. You can also provide these patients with oxygen. So these patients usually have oxygen nasal cannula for which they go home and they continue therapy over there. They could be treated with beta-2 agonists like albuterol, anticholinergic agents like ipratropium, as well as corticosteroids like budesonide. And if there is a COPD exacerbation in these patients, then you can provide them with antibiotics like, for instance, azithromycin or levofloxacin, to help these patients get over the COPD exacerbation. There are also complications that can arise from the COPD, and these include the secondary polycythemia. So since these patients have chronic hypoxemia, the body will start to increase the blood production to compensate for the decreased level of oxygen, and thus these patients develop secondary polycythemia. In addition, since there is a pulmonary hypertension, there is an increased work of the right heart, as a consequence of which these patients will develop right ventricular enlargement. And this condition, where pulmonary hypertension causes right ventricular enlargement, is referred to as cor pulmonale. And these patients will eventually require heart and lung transplantation. Now, there are medications that you can prescribe to help control pulmonary hypertension, and these medications include the bosentan, which is the endothelin-1 receptor antagonist. You can also provide them with the prostacyclin medications, like, for instance, epoprostenol. And then finally, you can provide them with the phosphodiesterase 5 inhibitor, sildenafil, to help control the pulmonary hypertension. And that concludes our discussion.